Very good evening, my friends who has joined from India. Good afternoon or good morning to those who have joined from other countries. And I am Matthew Philip, the Secretary General of Indian Society of Gastroenterology. I am so happy to welcome all of you for another joint session of GAPIO and IST. GAPIO stands for Global Association of Physicians of Indian Origin. And we are bringing in another very interesting session of early detection of diseases in gastroenterology. You know, we have taken up two topics. One is from liver, and another is from GI cancers. And we know that fatty liver is so common, and we know who should be worried about, or which patient should be referred for evaluation. And we have got two wonderful speakers, and also early detection cancer from GI tract. Now we know that if you detect them early, it can be easily cured. And many times, 40 to 50% of patient comes with very advanced tumors, and we may not be able to cure them. So this can be corrected by early detection. And this session is digital outreach partner is Docplexus, and it is the official YouTube channel is streamlined in the GAPIO YouTube channel. And we have, I want to introduce Dr. Pramod Garg, a very illustrious person of GI fraternity in India. And he is currently the president of Indian Society of Gastroenterology, and he is the HOD of gastroenterology of All India Institute of Medical Sciences, and is a very renowned physician and gastroenterologist with a large number of very important research contributions in gastroenterology, particularly in pancreatic diseases, and he has developed new effective therapies in pancreatic diseases. He has published more than 275 articles in very important, highly indexed journals like JAMA, Gastroenterology, and Gut. And he has got an H index of 68, and he has got more than 33,000 citations. He is also a J.C. Bose Fellow and a Fellow of all 4 national science societies, and has been conferred with many awards in India. He is also the editor-in-chief of International Journal of Pancreatology, and we are very fortunate to have him here as the chairperson of conducting this session. So Dr. Pramod, start with his welcome words, and he's the president of Indian Society of Gastroenterology.
Thank you very much, Dr. Matthew Philip, for this very kind introduction. I'm thankful to the leadership of GAPIO, who has initiated this very important online seminar series between GAPIO and Indian Society of Gastroenterology. I think this is an excellent platform for learning. Indian Society of Gastroenterology always strives hard for dissemination of knowledge and sharing of ideas and concepts. And I think today's seminar will go a long way, not only in educating all the people who are joining this online, but also furthering our collaboration between GAPIO and ISG for fruitful happenings in the future. I'm happy to note that we have 2 eminent speakers today for this webinar series. The first one is going to be Dr. Harikumar Nair, who is a senior gastroenterologist, hepatologist at the WellCare Hospital, Kochi. His special interest is in liver disease, particularly transplant hepatology, therapeutic endoscopy, and many other areas. And he has contributed not only to patient care, but also to research. Welcome, Dr. Nair, to this webinar series, and he's going to talk about fatty liver disease. And as all of you know, it's a very common problem, and people are worried whether or not they should do something about this disease. With the availability of so many newer pharmacological treatment, I think it becomes very important for us to educate our physician colleagues who care for patients in the community. So over to you, Dr. Nair, for your talk on fatty liver disease. Thank you.
Thank you, Professor Garg, for the kind introduction. Let me share my slide now. Let me thank GAPIO for this opportunity, and let me thank Dr. Matthew Philip as well for this wonderful opportunity. I hope my slide is, my screen is visible now. Hope the slides are visible now.
Yeah, yes, you are. Make it slideshow. Yeah, good. Thank you.
Um, Good evening for those of us who have joined from India, and greetings from those who have joined.
Dr. Hari, let me make one housekeeping announcement. Those who want to, delegates who want to, or the participants who want to put questions, please put in the chat box, and that will be transferred to us, and then we'll take up the questions at the end of both the talks together. Thank you. Sorry, Hari.
Yeah.
Carry on.
So this particular topic, as Professor Garg rightly put it, we are in a transition phase of fatty liver disease management with a lot of newer medicine molecules coming into the picture. But more importantly, this is a medical entity. If you ask me, in next coming decades, which is a commonest medical entity across all specialties, it is going to be metabolic dysfunction associated steatotic liver disease, with a population prevalence of 25 to 30% nationally and globally. Some niche populations would, the prevalence would go up to 60%, and clinical entities like central obesity, type 2 diabetes, it is of the tune of 80%. So we are dealing with a highly prevalent disease. Our focus today is to who should we worry about, because we obviously, due to financial reasons, health economic concerns, we won't be able to screen the entire population. So general population screening is not possible. So how do we filter out people who are at risk? So risk stratification, who should we worry about? Next 15 to 20 minutes, we will be navigating through these headings. The older name is much more familiar to physicians across the globe: non-alcoholic fatty liver disease, NAFLD, which has given way to the new name and definition, MASLD, metabolic dysfunction associated steatotic liver disease. And we would see why this was done, what was the reason behind this change in nomenclature, and we would touch upon the epidemiology as well, nationally, globally. Regarding natural history of the disease, this spans over 10 to 20 years, 2 to 3 decades in fact, and this gives us a wide window of opportunity to intervene in terms of the initial 10 or 20 years until fatty liver disease becomes cirrhosis or liver cancer. There is a reversibility potential, but then this happens only in the asymptomatic phase. So all the more reason for us to discuss how to pick up the high-risk people so that we can attempt reversibility. So regarding clinical presentation, all of us know that this is mostly an incidental detection, asymptomatic mostly until the late stages. So looking at clinical features, symptoms, we may not be able to risk stratify or find out who's at risk, but the attendant metabolic risk factors, diabetes, systemic hypertension, dyslipidemia, and the attendant vascular complications, all those can be picked up. Now, the core of risk assessment would be on assessment of fibrosis. Let's get familiarized with the terminology. NAFLD has become MASLD now. The older definition of non-alcoholic fatty liver disease, 5% of liver cells are steatotic in those who do not consume alcohol, and liver biopsy was indicated for this older definition, especially the inflammatory version of fatty liver disease, liver biopsy was indicated. While when we come to the newer nomenclature, MASLD, post-2023 Delphi consensus, it's very simple definition: steatosis in imaging or biopsy, plus one cardiometabolic risk factor. Liver biopsy is not mandatory here. So among various other reasons why this nomenclature change happened, an important reason was that majority of fatty liver disease is being seen in non-hepatology settings at community physician level, at internist level. So the definition was simplified with an intent that preventive strategies can be employed only if we get inputs from the internists, GPs, or community physicians. All these terms we are familiar with. ALD, alcoholic liver disease, and we have an inflammatory version of it, which is alcoholic steatohepatitis. MASLD, the newer name, metabolic dysfunction associated steatotic liver disease. The inflammatory version of it is MASH, metabolic dysfunction associated steatohepatitis. The new kid in the block is MET-ALD. This is not an uncommon entity. Many a time, if we do an audit of our ambulatory care practice, those who have cardiometabolic risk factor like diabetes, hypertension, or dyslipidemia would be drinking as well, but in moderation, quote unquote, alcohol consumption in moderation. That is the difficult part of it, to quantify, alcoholism. But certainly, this is a new entity which has got its own implication in terms of prognosis as well as therapeutics. MET-ALD. Sometimes, clinical practice guidelines can be impractical. We need not go into details of this guideline. Let's move from above below. Is there fatty liver disease in imaging or biopsy? Yes, no. Is there a presence, do we have a cardiometabolic risk factor here? Yes, no. And below this point, it's all about quantifying alcohol, more than 20 grams per day for women, more than 30 grams per day for men, more than 50, more than 60. So based on alcohol quantification, we ultimately segregate the morbidity entities like pure MAS LD, alcoholic liver disease ALD, and the in-between entity MET ALD. But practically all of us know that this is a big confusion. Alcohol intake, as we all know, there is no age, gender, or ethnicity specific upper limit of non-hazardous drinking. And the most difficult part is alcoholics are never honest when it comes to disclosing their drinking pattern. We ideally should be relying on blood markers, but unfortunately at this point, we don't have a foolproof one. In India, we commonly look at mean corpuscular volume, GGT, or gamma glutamyl transaminase. We do have CDT as well, carbohydrate deficient transferrin, not very commonly used again. But the newer marker for alcoholism, phosphatidyl ethanol, is being used in the Western world, especially in transplant centers, those who are listed for liver transplant, to make sure that they maintain sobriety. This PETH, phosphatidyl ethanol, is being used. But in Indian practice, and for that matter, for a GP practice in the rest of the world as well, no clear alcohol markers are available. Looking at the epidemiological figures, as I mentioned in the beginning, general population nationally and globally, it should be roughly around 25 to 30% prevalence. And in some select clinical entities, niche areas, obesity, type 2 DM, diabetes mellitus, it is of the tune of as high as 80%. I would like to attract your attention towards two local figures from Kerala. The capital city of Kerala, Thiruvananthapuram, has a published British Medical Journal 2019 publication. 49% was the prevalence, which means every other person, 1 in 2, has got fatty liver disease here. And among children, overweight children, 60% is the prevalence of fatty liver disease. 2 studies from Kerala, one in northern district of Kannur and second is from southern district of Thiruvananthapuram. So we are not dealing with an adult entity. This is a pediatric problem as well. Imagine the kids with fatty liver when they grow up, the metabolic aftermath which we are going to tackle. So this epidemiological scary figures underscore the importance of this topic today. Among etiology of chronic liver disease, as I mentioned, 10 to 20 years spanning fatty liver disease belonging to ALD, alcoholic liver disease, MAS LD, and the in-between entity MET ALD constitute 70 to 80% of the result. All the rest of the etiologies seem to be shrinking, especially hepatitis C with efficient treatment that's shrinking. These two steatotic liver diseases progress in a stereotyped manner. To begin with, accumulation of fat, bland steatosis, then inflammation of liver cells happen, SGOT and SGPT in LFT gets deranged, and ultimately through various stages of fibroprogression, liver scarring and cirrhosis result. What is to be remembered is 90% of the patients who visit us are having bland fatty liver disease, while 10% will have a deranged LFT, signifying inflammatory fatty liver or MASH, metabolic dysfunction associated steatohepatitis. And in this 10%, 25 to 40% roughly can move on with fibroprogression and cirrhosis. So we should be focusing on those who have a persistently abnormal LFT, SGOT and SGPT elevation. 2 to 3 decades spanning progression, the patient can present at any of these stages of spectral progression. Healthy liver transforms into simple or bland fatty liver. Then inflammation sets in. Liver is in fire, but the patient is not in fire because it's an asymptomatic disease. And ultimately, various stages of fibroprogression, liver cirrhosis, and hepatocellular carcinoma. If you look at the Indian practice as well as on either side of Atlantic or Asia Pacific region, at each stage we don't lack diagnosis. We have diagnostic armamentarium. We do have diagnosis at each stage, but what we lack is risk stratification. Can we do risk stratification and identify who is at risk from clinical features? Obviously, no. Mostly an asymptomatic entity, mostly an incidental finding, which comes out of an ultrasonogram ordered by a non-hepatology specialist, gynecologist ordering an ultrasonogram, urologist ordering an ultrasonogram. The common symptom would be a presentation would be a vague right upper quadrant pain. In fibroprogress disease, fatigue can be a symptom, but once a patient ends up in a cirrhosis stage, then symptoms start popping up. But then, unfortunately, this is not the stage where we should be risk stratifying, because reversibility is not guaranteed. Once a patient enters the phase of liver cirrhosis, we need to pick them up early. Clinical features or symptoms won't guide us, but then the attendant accompanying metabolic risk factors, type 2 diabetes, hypertension, dyslipidemia with insulin resistance at its center, the macrovascular ill health, all those can be picked up. And this is where we should be focusing on when it comes to screening. Do we have to only focus on obese people? Fatty liver disease, does it pertain only to obese? No. There is an entity, lean fatty liver disease, because it's a mix-up of lifestyle. It's a lifestyle disorder, of course, but then it's backed by genetics as well. Many mutative genes have been identified, the first one being T and PLA3. So even if the patient is lean, he can be metabolically unhealthy. I would like to introduce two terms here, MON-W and Toffee phenotype. MON-W is metabolically obese, normal weight individual, and Toffee phenotype is thin outside and fat inside. This lean metabolic dysfunction is an Asian entity. So we need to look at lean people as well, those who are metabolically dysfunctional. So let's summarize the clinical problems and felt need when it comes to risk stratification. The clinician's need goes like this. Fatty liver disease spanning over 10 to 20 years is often silent, progresses from gland steatosis, inflammation, and fibroprogression. Reversibility can happen only in the early asymptomatic phase, and we have to focus on early fibrosis detection. Biopsy is not feasible for all patients, especially at community level, and there is a demand for reliable non-invasive tool. Out of the three histopathological components of fatty liver disease progression, which one should we be focusing? Fat, inflammation, or fibrosis? In fact, fat is not the real enemy. It is fibrosis where we should be focusing on. Why should we evaluate and quantify liver fibrosis? As I mentioned, the initial asymptomatic phases of fibroprogression, F1, F2, F3, this is the ideal time where we should pick up this entity and try to attempt the reversibility. Reversibility can happen in the silent phase, while F4 stage of fibrosis, especially in the decompensation phase of cirrhosis, F4 is pretty much cirrhosis, and once decompensation sets in, absolutely there is no question of reversibility, and the patient would end up at transplant at some point. And one more important point to be remembered here is fibrosis assessment is not just for liver alone. In fact, it signals vascular ill health. So we would invite, in a fibroprogressed fatty liver disease, we would rope in the cardiologist to do a coronary artery disease workup as well. Just like when we encounter diabetic retinopathy, the nephrologist has to chip in, because these two are microangiopathy. Likewise, liver fibrosis, we have to seek help from the cardiologist to look at macrovascular complication, coronary artery disease. So unfortunately, when you do a reality check, practice audit, it's mostly an incidental finding in ultrasound taken for some other reason. Asymptomatic disease, there are three common practice trajectories. Number one, disregard. It's just fatty liver. It's a very common problem, and nothing need to be done. Second trajectory is over-investigation of low-risk cases. That's because we don't know whom to focus on. And the third, under-investigation of high-risk cases. I'm sure those of us practicing in the Western world, there certainly would be guidelines for GPs to filter and screen. While in India, we in actual reality we don't have such a rigid guidelines in place. What makes us what prevents us from risk stratification? It's not the difficulty of doing a liver biopsy, because liver biopsy is rarely indicated to assess fibrosis. Most of the time, we should only be looking at the non-invasive markers. Here, I would like to stress upon the magic number of 1.5 lakh platelet count. This has immense importance. Those of us who follow up a metabolic syndrome patient, a diabetic patient over years, if the platelet counters seem to be dipping down and reaching 1.5, this is a signal that he has gone into clinically significant disease in portal hypertension. So this platelet count is inculcated into FIB4 and EPRI. You combine a few other parameters and then arrive at the smartphone calculators available in the smartphone, FIB4 and FP. And then based on the score, you move on with an imaging, the commonly done being fibroscan. MR elastogram is diagnostically accurate, but then it is not practically feasible due to cost concerns and availability heuristics, as well as claustrophobia associated with it. So risk stratification, step 1. Whom to worry about? Step 1, blood-based markers. So there are non-patented blood tests, FIB4 and FP, and patented blood tests, FibroTest, ELF, and Fibrometer. The patented ones are rarely done in India, especially because some exotic blood investigations like hyaluronic acid and alpha-2 macroglobulin are needed here. We go by FIB4 mostly, age, AST, ALT, and platelets into a formula. And this is a calculator readily available in smartphones. Risk stratification, step 2. When to refer to a hepatologist or gastroenterologist for fibroscan. Look at FIB4. If it is less than 1.3, then reassess FIB4 1 to 3 years. Keep it with the community physician or internist. Employ diet and lifestyle modification. If FIB4 is more than 2.67, this is the time for a referral to hepatology or gastroenterology or fibroscan. And in between score 1.3 to 2.6, we can employ personalized medicine principles. We'll come to that soon. So in summary, how to assess fibro progression? Of course, it has to start with clinical examination to make sure that the patient hasn't reached cirrhosis. Clinical examination findings are positive only in the stage of liver cirrhosis or F4 fibrosis. Now, lab test, as I mentioned, 1.5 lakh platelet has got immense importance. Is the protein profile changing, albumin globulin ratio reversal, then that's a pointer towards cirrhosis. FIB4 is the main non-invasive entity which we look at. Based on this FIB4, we go for imaging. Of course, ultrasound brings us a wealth of information, but these are all pertaining to the later stages. Surface nodularity and volume distribution changes, fissural widening of liver cirrhosis, but for an earlier fibrosis detection, we have to go for fibroscan. So who should be screened? Whom should we worry about? Age more than 50, 1 or more cardiometabolic risk factor. FIB4 more than 2.67. As I mentioned, we can certainly employ personalized medicine decision makers. Add-on effect of cardiometabolic risk factor. If there are more than one cardiometabolic risk factor, diabetes and hypertension together, that has got more fibro progression predilection. Type 2 diabetes and obesity are the strongest fibro progressors, and those with persistently deranged steatohepatitis. Of course, hypertension and dyslipidemia also can contribute. Though significant alcohol consumption, of course, is a strong fibro progressor. Gynecology practice, PCOD, polycystic ovarian disease, obstructive sleep apnea, postmenopausal status, abdominal obesity, those of us who have accessibility to bioimpedance assay or DEXA to look at body composition, visceral obesity, lean fatty liver disease also to be given importance, the entity of MONW, metabolically obese normal weight individual, and TOFI phenotype, thin outside and fat inside phenotype. So all these factors can be factored in terms of those who have a FIB4 between 1.3 to 2.6. Let me conclude. Who to worry about? Age more than 50 years, postmenopausal ladies, and 1 or more cardiometabolic risk factors, CMRF. Among in CMRF, obesity and type 2 diabetes mellitus are the most important determinants of risk of cirrhosis and HCC. Screening of fibrosis to be done on at-risk population with blood-based marker FIB4 as a referral logic or a start point. The idea is to identify asymptomatic early fibrosis and explore feasibility of fibro regression or reversal. And last but not the least is the fact that liver fibrosis assessment is not just for liver. It signals for macrovascular health, and we need to seek help from cardiologists. Cardiology inputs to be taken, and coronary artery disease work to be done. Thank you very much.
Thank you very much, Dr. Nair. Matthew, should we take up questions at this stage or finish up both the talks?
We will have Dr. Prakash talk, and then later we can have last.
Okay, I agree. So, thank you, Dr. Nair, for this excellent talk. And now I would invite Dr. Prakash Zacharias, who is a senior consultant gastroenterology and chief of endoscopy at Lisi Institute of Gastroenterology, Hepatology and Transplant, Lisi Hospital, Cochin. He has extensive experience and interest in advanced endoscopy, liver diseases. Areas of interest include third space endoscopy, early detection of GI cancers, international EUS, and published multiple papers in national and international journals, and has been a second runner-up in World Cup of Endoscopy in Washington 24. Dr. Zacharias is also a council member of Indian Society of Gastroenterology, and it's my pleasure to invite him to talk about detection of GI cancers. As we all know, late detection leads to very high morbidity and mortality. So what do we do in the community, I think, is the key question. Over to you, Dr. Prakash Zacharias. We can see your slides. Yeah, go ahead.
Good evening. Am I audible?
Yes, please go ahead.
Yeah. Thank you, Professor Garg, for this nice introduction. So in this session on early detection of GI diseases, I would be talking about the detection of GI cancers, what every physician should know. So before I take you to GI cancers, I would just take you through the global scenario of cancer at present. So in 2022, the estimates from the International Agency for Research on Cancer was published, and it was found that about 20 million new cases of cancers are reported every year, and 1 in 5 men or women develop cancer in a lifetime. And India ranks third in cancer incidence after China and US. Among the most frequently diagnosed cancers, there is colorectal and stomach. So the incidence of cancer varies from country to country. And in India, it is the oral cavity and lip cancer, which is the commonest one. And in some areas, the esophageal cancer also. While other parts of the world, it's either lung or prostate cancer in male. However, in female, it is the breast cancer which predominates. As in other parts of the world, in India also, there is an increasing incidence of cancer as the years go by. So once the age increases, there is an increased risk of cancer. Among the top leading sites of cancer in India, there are cancers from the esophagus, stomach, and the rectum, and about which I would be talking about. So I would first talk about the esophagus, followed by gastric, and then colorectal cancer. So in the esophageal cancer, the most common, it is seen in the eastern part of Asia, and in Malawi, it is has the highest incidence rate, and in Bangladesh, it is one of the leading cause of cancer death. The esophageal cancer can be either squamous cell cancer or adenocarcinoma. The squamous cell cancer, the risk factors are smoking and alcohol and betel nut chewing. While in the adenocarcinoma, it is more commonly seen in the high human development index countries, and the risk factors are excess body weight, gastroesophageal reflux disease, and Barrett's esophagus. So let me take you through an endoscopic picture of a patient who came with dysphagia. And here you can see an obstructing growth in the lower esophagus. And on narrowband imaging, you can see that there is a nodular area with vascular changes and areas of avascularity. And this patient, on further evaluation, was found to have a T2 tumor. So most of the time, patients with esophageal cancer present in an advanced stage, and hence the 5-year survival rate for esophageal cancer is 10 to 30% after diagnosis. So this is all across the world. And males have a 3-fold higher incidence and mortality rates than females. The higher incidence of adenocarcinoma is seen in the Northern Europe and North America, and squamous cell carcinoma is more in the Asian and South Africa, and also in South America. The risk factors of esophageal cancer are there are others, but the most important ones are smoking, alcohol, and past or concomitant squamous cell carcinoma in the head and neck. While smoking has got a 5-fold risk, alcohol is those persons who have got an alcohol dehydrogenase 2 deficiency has got a 77-fold increase in risk of squamous cell carcinoma. And these persons can be identified by having flushing after intake of alcohol. So those patients who have got head and neck cancer, there's an 8 to 22-fold higher risk of squamous cell cancer, and it is worth doing an endoscopy in this group of patients. And early lesion detection is not an easy thing because the precancerous lesions can be inconspicuous by the routine white light endoscopy because these can be an elevated, flat, or a depressed lesion. So I'll take you through an endoscopy of a patient who had recurrent some chest pains, dyspeptic symptoms who underwent an upper GI endoscopy. This may be turned away as a normal endoscopy, but on careful looking, in the lower esophagus, you can see a little bit of abnormal area, and on narrowband imaging, you can see that there is a well-delineated lesion here. And this later on biopsy showed an early esophageal cancer. So in early esophageal cancer detection, you can also employ what is called a chromoendoscopy. This is spraying of a dye. There's a leucocidin being sprayed. And leucocidin, it contains iodine and potassium iodide. This reacts with the glycogen in the squamous mucosa, and this leads to a brownish discoloration. However, the dysplastic lesions will not be staked. So here you can see a long early esophageal lesion, a dysplastic lesion, and surrounded here in the proximal part, there is a normal lesion. So usually what we use is what is called a narrowband imaging, where a filter is placed before the white light. And as you know, the white light composed of red, blue, and green colors. And here the red is filtered out. And here you can see in the mucosa, the superficial vessels are seen as brown, and the deeper vessels are seen as cyan colored. And this can be used to see the subepithelial vessels on endoscopy. And this is the subepithelial epithelial capillary network. In the superficial part, it comes as an intrapapillary capillary loop. And this on endoscopy looks like this. And in magnification endoscopy, you can see this. And when an early lesion or cancer occurs, and this IPCL will become thickened and the loops may straighten out. So this is a patient who had an early lesion, and in the narrowband imaging, you can see some avascular areas, the thickened IPCLs. Some of these IPCLs are straightened out. So the loops have been lost, and this is an early esophageal cancer. So NPI can be used for early diagnosis and with a sensitivity of 97 and accuracy of about 90%. So this would help us to classify these patients into a T1 lesions or T1A or a T1B, depending on the IPCL characteristics. And by classifying this, you can choose patients for endoscopic resection. So the first patient whom I mentioned later, so underwent endoscopy submucosal dissection. After marking the whole area, the submucosal injection was done and the incision made, and an underwater submucosal dissection is being done here. So this is a submucosa which you are seeing, and the dissection is being made, and the whole lesion is slowly cut out from the submucosa and completely removed en bloc. And this was an R0 resection, and this was an early esophageal cancer. So when you have a T1 early lesion, there is endoscopic submucosal dissection has got an equal survival rate or is equal to surgery with a disease-free survival of more than 90%. And the advantage of endoscopic submucosal dissection is that you have got fewer complications, less duration of treatment, less hospital stay, and it is superior to even radiotherapy, safer and less expensive. So endoscopy and image-enhanced endoscopy can be used in Barrett's esophagus. This is a patient who has got a Barrett's esophagus where there is extension of the columnar metaplasia into the lower esophagus. Here we are spraying a dye, that is the acetic acid, into the lower esophagus. There is an aceto-whitening which has happened here, and this is due to reaction with the sulfhydryl moiety. And here, after 1 or 2 minutes, you can see that those dysplastic lesions lose the aceto-whitening. So you can differentiate the other areas from these dysplastic areas by the loss of aceto-whitening, and then target biopsy and also do a resection. And this has got a good sensitivity rate. So narrowband imaging, as I mentioned earlier, can also be used to see these lesions and predict whether this is a invasive or a non-invasive lesion. And another advancement in endoscopy called endocytoscopy can also be used along with it, and an endobrain combined with an artificial intelligence can predict whether this lesion is neoplastic or not. So early detection would lead to an endoscopic resection in those patients with esophageal cancer and will give you a high cure rate. Coming to gastric cancer, it is more common in Asian countries, and this is more seen in those people who are more than 50 years. Men has got a twofold increase. Siblings or a first degree relative, if they have got a gastric cancer, then there's a 1.5 to 10 times risk of gastric cancer. If there's a H. pylori infection along with intestinal metaplasia and gastric atrophy, there is a risk. If the patient has got a previous endoscopy resection for gastric cancer, there can be a metachronous lesion in 7 to 15%. There are some inherited syndromes also which predispose person to gastric cancer. In the global trends of cancer survival rate, you can see that the gastric cancer has got a 5-year survival rate only of 20 to 40%, while the highest survival rate is seen in Korea and Japan because they detect early lesions. In India, by the time the patient presents to us, has got an advanced lesion. So patients with gastric cancer can have either a lower stomach lesion or an upper stomach lesion, and lower stomach lesions are usually due to H. pylori infection, and the upper stomach is less due to H. pylori infection, can be due to other causes also. So those people who have got a H. pylori induced gastritis, it goes through multiple phases. First, after some time, there can be atrophic gastritis, then intestinal metaplasia, dysplasia, and finally leading to adenocarcinoma. So if you can detect this area where this patient has got dysplasia, then you can prevent the person from developing a cancer. Or if it's an early cancer, you will can give the patient a cure also by endoscopic resection. So gastric cancer screening can be done in population-based, provided the population is a high risk or endemic region, or it can be a targeted screening in those people who have more than 45 years with family history of gastric cancer, or more than 50 years with pernicious anemia, or along with being a male sex, smoking, or and having a family history of gastric cancer. But the other most important one is opportunistic screening. That is, whenever we do an upper GI endoscopy, utilize that procedure as a screening procedure for gastric cancer as well as esophageal cancer. As we saw in the first case, I showed that lesions cannot be sometimes visualized unless you do a careful endoscopy. Why we should detect these lesions, that the 5-year survival rate for patients with early upper GI cancers exceeds 85%, while in advanced cancer it is only 20 to 40%. So when we do an upper GI endoscopy, we do a systematic screening protocol called SSS protocol. We look at the nook and corner of the stomach so that we will see whether there are areas of intestinal metaplasia and intestinal atrophy, so that you can pick up lesions. We look for microvascular pattern changes as well as microsurface patterns, see for any line of demarcation or abnormal areas, and then take just a biopsy to confirm this. And then, as in this patient, you can do an endoscopic resection. So this patient had an early gastric cancer. So after marking the area, we started a submucosal dissection, and using a traction technique, we completed the submucosal dissection. So once this dissection is done, you can have an en bloc resection, and this patient finally turned out to be only an early esophageal cancer with no deep invasion into the submucosa. So early lesion detection can lead to endoscopic resection and cure. Colorectal cancers have been reportedly more common in Western countries. However, in India, as the age advances, it has been found that in male and female as well, the incidence of colorectal cancer increases. And even in India, there are changes between different parts of the country. For example, in Mizoram, parts of Assam, and even in Kerala, there are areas with the incidence is more than 10%. So the colorectal cancers, there are certain factors which can increases the risk, and there are some protective factors also. In the global trends in cancer survival rate, the colon and rectum in India, the 5-year survival rate has been only 30 to 39% compared to others which has more than 70%. And this is due to a late detection of colorectal cancer, because these patients present very late and there is no screening program. And colorectal cancer, it develops through a different phase. From adenoma to carcinoma, it happens over a 10-year period. Most of the patients have this adenoma-carcinoma sequence in 70%. In about 25 to 30%, it can be an SSL, a disseminated lesion to carcinoma pathway, or sometimes familiar cancer syndromes or IBD-related cancers. So colorectal cancer, by screening by a screening colonoscopy, can reduce the overall colorectal cancer incidence and also reduce the colorectal cancer mortality. But a very less invasive FIT test, the fecal immunochemical test, can be used, which has a cutoff of 20 milligram of hemoglobin per gram of stool. So this has got a sensitivity of about 80% and specificity of 94% for colorectal cancer. But if it is an advanced adenoma, it comes less. And sessile serrated lesions, the sensitivity is much less. So if you can have either do a FIT every year or a colonoscopy every 10 years for screening, or you can use one of this, that is multi-target stool DNA test, flexible sigmoidoscopy, or a CT colonoscopy. So whom to screen for colon cancer? This is, mind you, this is for colon cancer. A change in bowel habits more than 45 years should alarm you to do a colonoscopy for a further investigation. Bleeding PR per rectum after 45 years, unexplained anemia, family history of colon cancer would definitely warrant a colonoscopy if it is more than 40 or 45 years. Familiar cancers, syndromes, and inflammatory bowel disease are a group where there are definite screening guidelines. And there are screening guidelines for this. And this, when we do a colonoscopy, what we look for are polyps, whether it's an adenomatous polyps or a hyperplastic polyps. If it is adenomatous, whether there are changes which look like a low-grade neoplasia or a high-grade neoplasia. This is by narrowband imaging. And if there are areas of amorphous areas, that indicates that it is a deep submucosal invasive tumor. So here on colonoscopy, you can see that there is an ulcerated lesion, amorphous areas, lot of mucin here, most likely a mucinous tumor and a deep invasive tumor. So this patient has to be evaluated for surgery. However, this patient who presented with a mucinous diarrhea with mucus and even hypokalemia was found to have a villus adenoma. Here, this patient underwent a submucosal dissection. This was an extensive lesion, circumferential lesion, and this is after dissection. This tumor was removed and blocked, and you can see that the whole lesion has been removed, and this can prevent an otherwise APR. So endoscopic resections are possible, and this patient's biopsy was only an intramucosal carcinoma, and there was no high risk factors. So this is the resected specimen. So to summarize, most GI cancers present at an advanced stage, leading to a low 5-year survival rate. Early diagnosis can lead to improved survival and cure. There are advances in endoscopy which has happened, and this which allow early detection and treatment of these patients. Thank you very much.
Thank you, Dr. Zacharias, for an excellent overview of early detection of GI cancers, which is actually very, very important. Thank you, both the speakers. And now we have many questions in the chat box. Dr. Matthew Philip, would you like to take up the question, or should I start asking?
And you can start, and thank
Okay,
you.
so first we will go to Dr. Nair for the questions on fatty liver. Dr. Nair, here are the questions. With the change from NAFLD to MASLD, has anything really changed in day-to-day clinical practice, or is it mainly a nomenclature shift?
Thanks for the question. In fact, this was mentioned in the beginning. When it comes to preventive strategies, this has to happen in non-hepatology settings, and the definition has to be simplified. The non-alcoholic was not capturing the actual etiology. The metabolic dysfunction, which is behind, fueling the entity, is not brought out. So without a liver biopsy, just focusing on metabolic dysfunction and imaging showing fatty liver plus one cardiometabolic risk factor. Very simple definition to be used in community setting. So this is the major change which has occurred, and in future we expect this change to reflect onto fruitful fibro-regression strategies. Identify at a symptomatic stage by community physician and then reverse.
Okay, thank you. Next is, how significant is lean MSLD in the Indian population, and should we approach it differently? How common, and is the approach similar?
Very important question. Thanks again. So out of fatty liver disease, roughly 10% would be lean fatty liver disease or metabolically obese but normal weight. Approach would be pretty much similar. Like, if in terms of screening, if the person has imaging-wise steatosis and one cardiometabolic risk factor, he fits into the definition of MASLD. And the rest of all strategies remain the same. There is no difference in terms of approach. But when we advise diet and lifestyle modification for obese MASLD, we obviously would request patients to focus on weight loss. But here, that need not be done. More focus should be given on physical exercise, which is the best insulin sensitizer.
Okay, thank you. The next is, should all patients with type 2 diabetes be screened for MSLD in fibrosis? If yes, what's the practical strategy?
So, global guidelines differ, but roughly if we average out everything, sum up everything, more than 50 years of age with type 2 diabetes mellitus, where steatosis is documented in imaging, then such people can undergo screening more than 50 years. If there is LFT derangement, obviously we have to certainly screen.
Dr. Hari, I just want to add upon that question. So does the duration of diabetes matter for screening?
Need not be. I mean, diabetes need not always be there for us to subject a person for screening.
No. Other way, it is other way around. I mean, a diabetic person should be screened for MSL. We know that we screen them for eye changes, we screen them for diabetic nephropathy, we screen them for food changes, we screen for many aspects of diabetic complications. Should we now recommend that all diabetic patients should be checked for fatty liver, because it is going to be an important morbidity and mortality among diabetic patients?
Yeah, that's
Do
a
you think
very
so? How?
it's an excellent suggestion, but I'm not sure whether any of the guidelines have inculcated this. But type 2 diabetes being the strongest, metabolic driver, diabetic patients should be subjected for a steatosis screening. If ultrasonogram shows steatosis, we obviously have to go ahead with the further steps of FIB4 and FibroScan. Yes.
So next question is related to that. If in the clinic you see a person above 50 with fatty liver and controlled diabetes with FIB4 less than 1.3, would you do a FibroScan or any other tests?
Need not, because FIB4 less than 1.3, it has got when we apply a tool clinically, we talk about negative predictive value and positive predictive value. So here, FIB4 is a screening tool with negative predictive value. So if it is negative, very high likelihood that this person doesn't have a clinically significant fibro progression. Less than 1.3, we need not subject him for a FibroScan. We can just continue with diet and lifestyle modification, control his metabolic sugar, which has already been done for diabetes.
So last question, let me ask, if FibroScan is done, what is the LSM value above which you will be worried?
So this is etiology dependent. In fact, when we perform a FibroScan, the inputs are age, gender, and etiology. So the cutoff can vary from MASLD to alcoholic etiology, and the new MET-ALD unfortunately has not been coded in the FibroScan machines. So coming back to the question, any figure above 10 kilopascal is significant, and that deserves an annual recheck. While less than 10, we probably we can be comfortable
but
with.
Above 8 is also a little worrisome, right?
It is.
Yeah, so 8 is kind of, yeah, okay. Thank you, Dr. Nair. So going on to the other questions to Dr. Zacharias about the GI cancers. What is the single most common reason for missing early GI cancers during routine endoscopy? I mean, person is undergoing endoscopy for, say, functional dyspepsia.
Yeah, thank you. That's a very interesting question. And the thing is, people have been doing upper GI endoscopy for long, and there has been the way we are looking at upper GI endoscopy has been different. So the thing is, doing a standardized endoscopy is a must. That's the most important thing. So for colonoscopy, we have been doing colon preparation, but upper GI endoscopy, we have never been doing that. And when we do an endoscopy and we see pictures, you can see a lot of mucus, maybe some residue there, which will impede your visualization of the mucosa. So having a good preparation, that is giving something a simethicone plus N-acetylcysteine mixture of fluid of liquid to have before about 20 to 30 minutes before the endoscopy, taking adequate time during the procedure. At least 7 minutes should be spent during an upper GI endoscopy, not like a quick in and quick out. No, that will you will miss out. So, and also when you there are patient stratification of patients before is also a good thing. So, for example, if it's a patient who is a smoker, who is more than 50 years, and if he has got a previous history of head and neck cancers, so then these are the high-risk patients. And then doing a systematic screening protocol, look at all the stomach in different parts, and then identifying lesions, looking for it, and then describing it in a standard fashion of classification would be the best way to pick up all these lesions.
Right. You did mention about AI during your talk. So has AI truly improved early cancer detection, or is it mainly in the less experienced endoscopists who will be, helped and guided by it?
Yeah, AI is the thing nowadays for everything. So even it has come to, it has been incorporated into endoscopy also. So the area where it has been used now is for adenoma detection, and during colonoscopy, especially as you mentioned, those people who are less experienced and would be able to pick up these lesions in a much better increased adenoma detection rate may occur. But for experienced persons, this may not really matter because they do it in a systematic fashion.
So, as you mentioned, for in the Western country, there is a screening program for the healthy people, right? For colorectal cancer. And in China and Japan, there are programs for early detection of esophageal and gastric cancer. Do you think in India, we should have such a program, particularly for colorectal? You mentioned the high incidence areas here.
So, India is a vast country with a big, huge population, and the government funding is not the one which. So people, there's a different ways. Some are from their own pocket, some government. So it's at present we don't have a good data backup to say that we should have a universal program of screening, but ICMR sponsored study is going on to see whether this screening program would be worthwhile in India.
So as of now, no.
Yeah.
Okay. So what simple and cost-effective tools can clinicians use to risk stratify patients in early stages?
So taking a good history is one of the most important thing, and especially there are areas of the country where certain cancers are more common, and there are certain persons whose habit also matters. For example, betel nuts, chewing, smoking, all those things. So, and those patients who have got a head and neck cancers. So a good history, and especially history of their habits, their family history, it would help us to stratify patients and then look, then have an individuals which would be the best persons to undergo screening.
So you mentioned that screening protocol as of today may not be applicable to Indian population. So do you see the non-invasive biomarkers can be used for early detection?
Yes, that would be one way. That's fecal immunochemical test. So even fecal occult blood test, though, but it is not as good as a fit. But that is something which can be used, and then go on to this. But the only thing is that it may not pick up a good advanced adenoma or SSL-serrated lesions. So, but it would be better to those persons who are more than 45, 50, every year they should do this and see. And if there is any warning signs like bleeding PR or rectum or a change in bowel habits, they should undergo a colonoscopy.
So that means in India today, we are only screening those who come with some symptoms. I mean, it's
That's
not
right.
applicable to the general population.
That's right.
Right? So can you outline a practical screening approach for people with high risk? In average risk, we understand, I mean, as of today, we are not ready. But high risk population, do you think there should be a screening approach?
Definitely. So first of all, we have a group like hereditary cancer syndromes and also inflammatory bowel disease, where there is a screening protocol in place. Then those patients who have got a family history of colon cancer are an important group of patients who should undergo a screening. And then those patients who have a history of bleeding PR per rectum, especially after the age of 45 years, they should not think that it is a hemorrhoidal bleed, but it is better to do a colonoscopy. Then those patients who have got a change in alteration in bowel habits or an anemia of recent onset, they should also be subjected to further investigations, especially looking for a colorectal cancer.
Right, but with the availability of so many tests, often what happens is that the patient is subjected to many tests. So general physician level, what kind of advice would you give to prevent over investigations?
So, stratify patients. Consider doing if FIT is fecal immunochemical test is available, do that, or a fecal occult blood test, and then. But that it should not be a one time. Every year it should be repeated.
So in India, as of today, are there some recent guidelines which the physicians should adopt, or your answer would be only identify high-risk people?
Yeah, that's right.
So there are no recent guidelines which physicians should know that this group of patients should undergo screening.
So far, at present, no. There are.
But people with family history of cancers,
Definitely,
patients
yeah.
with IBD, I mean,
So
these are the patients who will definitely require.
Yeah, those
familial
guidelines are
cancer
already in place,
syndromes.
yes. Definitely, they should undergo.
Any person above the age of 50 years, any recent change of bowel habits, I think, and any hematochezia should not be. All hematochezia should be dealt with significant importance, and I think especially in elderly people, and we always look for the high risk features and that. And also, Dr. Pramod, I just want to add a point here. We are actually in India, multiple centers involving 7 to 8 centers in India are actually involved in the ICMR project of colorectal cancer screening. Once this study is completed, fortunately, Lizzie is also part of it. Once this is completed, I think we may be able to give some guideline whether we need CRC screening in India or not. And as Prakash told, India is a wide country. There is a lot of regional variations in food habits and living standards. So it actually could vary on that. And other thing is that, the question Dr. Prakash told about upper GI endoscopy, how we can enhance the yield, is basically a standardized endoscopy approach. And I'm happy to say that Dr. Pramod and myself, we are involved in structuring a guideline for how to improve the quality of upper GI endoscopy and how to standardize. And it is going to be published soon. And this will actually give us a very good guideline how to enhance the detection of early gastric cancer in upper GI endoscopy. And this is especially for gastroenterologists. And for physicians and all others, I think look for high-risk features. Anything abnormal, refer and send for a colonoscopy or whatever type of investigation you want. Any alarm symptoms in a person should be considered as important. Never deal with antibiotics for a person 50 years and above coming with a bleeding by rectum. Never try with just antibiotics or consider it as a food-related infection or whatever it is. But we has to be taken history very properly and do that. And I think we are ending the time. Dr. Pramod, you want to make a final comment?
So I would like to first thank both the speakers and the moderator, Dr. Matthew Philip, and the leadership of GAPIO, who has organized this very important, very educative webinar. For the physicians who have been listening in, my only advice as a gastroenterologist to them would be that if a patient comes to you with any of these alarm symptoms, when it comes to fatty liver, anybody who has a cardiometabolic risk factor, clinical obesity, now the word which is used is clinical obesity, and diabetes, you must look for signs of liver disease. Symptoms are hardly there, but on investigation you may find on ultrasound, and then simple tests like liver function test and platelets, as Dr. Nair had mentioned. Then you can risk stratify to find out those who require further workup. But I think the general advice about diet and exercise is extremely important at your level. When it comes to early detection of cancers, as Dr. Zacharias mentioned, that don't miss warning signs. Change in bowel habits above the age of 50, anemia of unknown origin, stool occult blood should be done, right? And then you can refer the patient to gastroenterologists for colonoscopies. In family history of cancers, early cancers in particular, then also patients with IBD, you must do screening colonoscopy. So there are many groups of patients where still we advise screening, but as Dr. Matthew Philip mentioned, that in times to come, we'll have more information in India to understand whether a screening program in the general population should be adopted. That will also not only require the data about the incidence of the disease, but also our current capacity to screen the general population. With these remarks, I'll hand over the mic to Dr. Matthew Philip for his final comment before we close.
So, Dr. Pramod, thanks a lot for the wonderful moderation. And I would like to thank Dr. Harikumar Nair, actually, it's a very pertinent question. We see a lot of fatty liver. Who should be selected for further evaluation? I think he has done a wonderful exposition of the knowledge and data available for fatty liver disease and who should worry about that. Thanks a lot, Harikumar, for this wonderful talk. And Prakash Zacharias, you have delineated all the various aspects of early GI cancer. It's a huge task to reduce this talk to 15 to 20 minutes. You have done so well, and also shown how what is the advantage of picking up early gastric cancer, how it can be dealt and make a cure for all these patients. And I also like to thank the audience who have participated. They have got very good participation, a lot of questions, and even now questions are coming up. And I also want to thank the office bearers of Gap Year for this joint session, and we have been doing it for some time and it's doing very well. And also the Docplexus team for this platform, and all the admin team doing wonderful work for this, which has been done so smoothly. So thank you so much. Bye now. We'll see with the second session after a few weeks or months. Thank you so much. And once again,
Thank
thank
you.
all
Have
the
a good day.
speakers and-
Namaskar.
Namaskar. Thank you so much. Jai Hind.
Bye-bye.
Thank you, sir. On behalf of Docplexus team, we really thanks each and every faculty member and all our viewers. Thank you so much. We are looking for many more collaboration with you, sir. Thank you.
Thank you. Bye.
Bye.